So thanks everyone for coming, and thanks for the last two presentations. They were very informative, and they'll be related to what I'll talk about here. My title is "What Can Psychometrics Tell Us About Multiple Sclerosis?" Here's a roadmap for my presentation. The introduction will be the next slide, slide 3, and there are two main parts to this. Part 1, I'll be talking about health broadly. I'll be talking about biopsychosocial health. So on the psychology side, I'll be talking about cognitive versus social engagement. I'll be talking about, on the more physiological side, also the bio side, diet and exercise. And then again, more on the body side, I'll be talking about neurodynamics. In part 2 of the presentation, I'll be talking about multiple sclerosis or MS and psychometrics. Uh, two MS scales I'll be talking about here are EDSS and MSFC. I'll go into what all of these acronyms mean on the given slides for them. And the 4 psychological scales I'll be covering here are STAI, HADS, GDS, CESD. And slide 15 will be my conclusion. Psychometrics is the measurement of the psychological status of people. Psychology includes affect, cognition, motivation, and behavior, as well as sensation, which is relevant for MS patients. Examples of psychometrics are depression and anxiety, any construct that we can numerically capture through the use of scales, surveys, and questionnaires. Psychometrics are discussed by people colloquially when they talk about, for example, being more intellectual or more feeling focused, being introverts or extroverts, and so on. Psychometrics help us compare how, for example, depressed or happy different people are. And with psychometrics, we can compare groups. One study found they were looking at the relative effects of cognitive conditions and social condition. And so in this study, 3 cognitively demanding conditions were administered. And these conditions include learning how to quilt, learning how to do digital photography, and learning how to do both of these. And there was a social condition as well, which was more passive. The sample for this study included people of ages 60 to 90, and the goal of this study was to strengthen memory. To do this, participants engaged in tasks higher in cognitive load and novelty, and cognitive load is simply how demanding a cognitive task is. What was found is there was a stronger effect in the learning conditions, so in the quilting and digital photography conditions, than in the social condition. In a different study, in a sample of mean age 56, diverse activities predicted healthier cognition. So the takeaway here is that a diverse range of cognitively demanding activities will predict healthier cognition, more so than passive social engagement. Moving on to exercise and diet, a randomized control trial tested the efficacy of the Mediterranean DASH. DASH stands for Dietary Approaches to Stop Hypertension, Intervention for Neurodegenerative Delay, otherwise known as the MIND diet. And the MIND acronym doesn't include the DASH part, but the DASH part is a part of the MIND diet. So that's a little confusing, but DASH is part of the MIND diet. The MIND diet includes leafy greens, other vegetables, nuts, beans, chicken, fish, and berries. Adults in this sample mostly had body mass indices of greater than or equal to 25 kilograms per square meter. They were at risk for Alzheimer's disease, and they were from Chicago and Boston. This study was more of a proposal and a design, however. It was based on promising findings that came before it. So the hypothesis that the MIND diet would delay neurodegeneration was well founded. In a different study, it was found exercise releases the brain-derived neurotrophic factor, or BDNF. And in another study, chocolate flavonoids were found to boost cognition. Talking a little bit about the brain itself and the nervous system, a big part of neuroplasticity is neurogenesis, and Torricelli et al. And Erickson et al. Looked at this in the hippocampus, which is responsible for long-term memory and also spatial memory. A preliminary result for neurogenesis was found in participants consuming heracinone and erinacine chemicals, which were found in the Hericium erinaceus or lion's mane mushroom. This is preliminary only, so this is not to be taken as a prescription for patients with MS. More research on this is required. The chemicals are available in capsule, tablet, and powder supplement forms, so they are accessible, but they should be used with caution and not necessarily for medical purpose just yet. In another study, nerve growth factor was found to lead to BDNF creation and myelin creation. So this is a viable anti-multiple sclerosis strategy. There are 30 currently active MS trials being conducted by Mayo Clinic. There are a lot of topics that I didn't include all of here, but topics include testing the effects of ofatumumab injection and siponimod, aspirin for fatigue, transplantation of stem cells, and MD1003. Also, SAR 442168's potential to delay disability and its relations to cognitive performance, physical function, and quality life are also being investigated. This is by Dr. Mark Keegan, if anyone wants to follow up on this one. So this is another broadly holistic health study, albeit for MS. Gray matter in relation to MS, not just white matter in MS, is also being studied. And experience and meaning, cerebrospinal fluid, that's by Dr. Sean Pittock, and sex differences in MS patients, as we heard about in our first presentation here, in MS patients are also being studied, among other topics. I want to go over two multiple sclerosis scales before I move on to psychometrics. EDSS is the Expanded Disability Status Scale developed by Kurtzka in 1983. This scale includes 20 items covering functional systems, walking or needs for mobile assistance, for example, using canes or wheelchairs, daily activity and communication. Scoring of EDSS consists of max scores of 0.5 per item. An overall score on the scale of 0 means normal, 5 to 6 means maximal impairment, and a score of 10 means death from MS in patients. MSFC is the Multiple Sclerosis Functional Composite. This is an alternative disability scale to EDSS. MSFC was created by the National MS Society Clinical Outcomes Assessment Task Force in 1994, and this task force included psychologists, neurologists, biostatisticians, and epidemiologists. And MSFC measures ambulation, so also walking, upper limb function, and cognitive function as well. So cognitive function has come up a few times here. Moving on to psychometrics for MS. What can these psychometrics tell us about the whole patient? Psychometrics is related to statistics. The prefix psycho and the suffix metrics together are the quantitative measurement of respondents' psychological statuses. Life satisfaction is an example of a relevant well-being metric, which I'll come back to later. But before I talk about life satisfaction, I'll talk about a few other scales. Mainly they're including depression and anxiety, as you see on the left Venn diagram here. But there are also other scales like the PHQ-9, or Primary Care Evaluation of Mental Disorders. That's PRIME MD. That screens for depression and suicidality from the prior 2 weeks. A number of these scales look at the last 1 or 2 weeks for the respondent. There are also the Multiple Sclerosis Impact Scale and the Perceived Stress Scale. The Multiple Sclerosis Impact Scale, or the MSIS-29, was made using a standard psychometric method of gathering patient interview and expert judgment, combining those, and then conducting initial testing. So the MSIS is unique in my presentation here because it includes both physical and psychological items. It's more physical. 20 of the items are about physical functioning, and 9 of them are about psychology. And all of the psychological items are about how patients being bothered by certain things, like being bothered by negative feelings. I will be covering the STAI, HADS, GDS, and CESD in the next few slides. The first up of these is the Spielberg State Trait Anxiety Inventory, or STAI. That's on the anxiety side here, so it's not measuring depression. It was made by Marteau and Becker in 1992. STAI's short form is 6 items and its long form is 40, so that's quite a difference. And the short form is therefore called STAI 6. The short form has 3 items on affect, and the other questions are on what I call being, or simply questions of how a patient is or was prior to taking the skill. The STAI measures present anxiety, so that's the state anxiety, and it measures general anxiety, which is trait anxiety. STAI 6 has passable reliability and was found to be valid in a sample of pregnant females studying nurses and medical students, which is a good sample with respect to STAI's use in the medical context. This gives some hope that this kind of skill can be extended to include MS patients. The next scale I'll be covering here is the Hospital Anxiety and Depression Scale, or HADS. This is the only scale here that I'll cover that includes items on both depression and anxiety. It was made by Zygmunt and Snaith in 1983. 14 of the items on this scale are about affect, so about feeling, enjoyment, humor, etc. And 1 item is about cognition, so it's definitely biased more toward the affect side. 7 items correspond to depression and 7 correspond to anxiety, so it's evenly split between those two. And the scoring criteria here are as follows. A normal score is 0 to 7, a borderline case is 8 to 10, and an abnormal case, so somebody with depression or anxiety, is 11 to 21. HADS is used in the general population. It was found to be reliable for ages 65 to 80, and it was valid for an emergency Arabic sample which sought to extend the study of the skill's validity in a more specific context that it wasn't used much in before. HADS has been used globally and in all healthcare settings, so it's a good bet to use for patients with MS. It is available in at least 8 non-English languages, and these versions are also reliable and valid. And the other languages are primarily European and more Western Asian. The third scale here is the Geriatric Depression Scale, or GDS. This was developed by Yasavage and Sheikh in 1986. GDS is used for the elderly population. Its short form is 15 questions that measure life satisfaction. So life satisfaction is coming up again here. It measures affect with 9 items devoted to that, and cognition with 2 items. And this is looking at the previous week rather than the last 2 weeks. Examples of questions from this scale are, do you often get bored? And are you in good spirits most of the time? A score of more than 5 yes responses on this scale. So if the respondent responds yes to questions like the 2 I just mentioned on more than 5 of the items, then that indicates depression. The long form of this scale is 30 questions, and GDS has demonstrated validity in various studies. Finally, the CESD scale, it's the Center for Epidemiological Studies Depression Scale. So there are 2 studies here that I'm looking at that only look at depression. HADS looks at depression and anxiety, but CESD was developed by Radloff in 1977 and is used in the general population as well. There are 10 items on affect and 2 on cognition, so there's already a trend emerging here from the last 3 scales I've talked about with more of a bias toward measuring affect versus cognition. CESD has decent reliability, test-retest reliability, and strong construct validity, so it's measuring what it intends to measure. This scale was last used alongside a sleep quality index and social support survey this year, and this scale has stood the test of time with extensive use. So as I just mentioned, there is a bias in the last 4 scales toward depression and affect rather than cognition. In addition to depression and anxiety, what other factors matter for those with MS? We've talked about life satisfaction, which is a well-being metric, and quality of life is an important one as well, which I'll come back to in a little here. Psychometrics, in conclusion here, can inform us of how populations are feeling and thinking. And with that, we can create a better model of how to reach well-being and brain healthiness and general body healthiness for each MS patient. And a relevant question there is, are there directions of predictiveness or causality that we can look at between psychometrics and more MS-focused skills, such as the correlation found between vision impairment and lower quality of life? So again, quality of life comes up here. Can psychometrics predict disability type or level? Can we, for example, draw any causal conclusions about a patient's negative affect being due to, for example, bowel or bladder dysfunction? Those are all important questions. And I'll end with more of a speculative question here is, are there any undiscovered psychological metrics for MS patients specifically? So not the usual clinical or well-being categories like depression, anxiety, or life satisfaction or quality of life. Are there other metrics that we don't even know about that are unique to the MS population? These are my references. Hopefully these are not too small. They're readable enough.
Thank you. Thank you so much. That pulled together really nicely. Very, very nice presentation. I'm very pleased with how that came together. And again, our slides will be available as downloadable PDF files. So for those who want to check the references, and I will start with an important question for you. Don't have to answer now, but we will need to think about and discuss. We will be doing an amendment to our clinical trial protocol that hopefully we can get written up and approved in the next month. A very important question for the 2024 amendment to our EPSMS clinical trial protocol will be which additional psychometrics should we encourage our trial participants to complete, and how are we going to deal with the opt-in versus opt-out matter? We've discussed in the past that we want to promote participation and cooperation with our trial participants by not, asking them to do 1,000,001 different questionnaires. So, which are the top half dozen that we should be asking them to really make an effort to complete as part of their participation in the trial? So don't need an answer right now, but that's something we need to have for the 2024 amendment to our clinical trial protocol. Let me ask for other questions from the audience.
Yes, I have a question, or rather a comment. There was at least one paper that I reviewed that talked about the differences between males and females with MS and their feeling of well-being and their ability to cope with things in the world. And it was clear from their data that the males did less well. Are there components of the psychometrics that you reviewed that can divide out that aspect of MS? In other words, the sexual dimorphism.
That's a good question. I'm a little rusty on like the gender differences ratio-wise between depression and anxiety. I know they exist, but another diagnostic criteria is autism spectrum disorder, which definitely has more of a bias toward males than females. I think it was 2 or 3 to 1 was the ratio for that. So if there are any other psychometrics that have that sort of skewing, that's important to look at, especially given the study that you looked at that showed that different genders do cope differently with MS. I think autism is the one that comes to mind most definitely for me. I think there is also a bit of gender bias with depression. Anxiety, I'm not so sure about. And it also depends on the where someone is in their life. If someone's pregnant, for example, um, just there are many other life factors that matter. So life satisfaction comes into that as well. What other problems are they facing, if any economic hardships? So that it's a pretty holistic question, actually.
Yeah. Well, one of the things that they pointed out in this particular paper was that the males with significant MS morbidity, in other words, they had significant neurological findings, were more depressed after the birth of a child than you would have expected because they were unable to participate the way they wanted to in that child's early development.
Right.
And it was quite striking because I think we don't think enough about that in relationship to people's disabilities.
Right. And that is covered. I didn't cover it really in my presentation, but another measure is just day-to-day life. So that's definitely covered in MS scales in general. Um, it's often in terms of functioning, but just day-to-day life, how is someone able to do what they should be doing or want to do? That's obviously relevant to life satisfaction. So if someone can't, it doesn't surprise me that they would be more depressed, even though there's a novel and exciting, event in one's life, like childbirth.
Well, my reaction to that was, is it is it loss of the parental role? So is it a reaction to so is it a deficit in the sense of loss of a role, or is it a deficit in the sense of loss of interaction with the newborn child? Um, but these are very important questions that I think really could and should be addressed, frankly, in the larger context of all of psychology in the general practice of the study of mood disorders. So I hope you'll look into that and see if you can come up with some recommendations. Because again, this is another one of the items that we should include in the 2024 amendment to our clinical trial protocol. Other questions? If not,
Sorry,
yes,
so
yes,
in on a, when discussing these, you talked about it being a bias toward affect, a bias toward anxiety over depression. So do you mean bias in the sense that you think it's so bias has a certain connotation as well as denotation. So do you think it's a bias in the sense that the there's a bias in the research community to ask about affect more than cognition and about anxiety more than depression and such? Or is it, do you think that's a conscious choice? Like, do you have a sense of why researchers choose what to look at the things they do?
Yeah, that's a really good question. My sense for that is it's interesting because in psychology, there was the cognitive revolution from the 70s to pretty much 2000, pretty much before cognitive neuroscience came onto the scene. There hasn't really been a revolution in psychology in affect, and yet when I look at all of these scales on depression and anxiety, or at least these four, there's a very clear bias, and the bias is in terms of the amount of items devoted to affect. So, for example, the items that I mentioned, that there's 9 or 10 compared to 1 or 2 on cognition. The items on affect start with, did you feel? So they explicitly use feel, and very few of the questions or items on these scales say, did you think or do you think? So those are the more general terms for affect and cognition, and those are what I base my evaluation of the bias there being. Um, it is interesting given the development of the field of psychology that discrepancy is here. Um, it's not so much when I look at depression. Depression often is discussed in terms of the loss of interest in things that, hobbies, for example, that one previously found enjoyment in. So I think part of it is the more general understanding of depression and anxiety. I'm not sure why there's a bias toward, or why there are more depression scales or items on depression here than anxiety. That's an interesting question. I'd have to think about that a bit more.
Well, if
I
if
mean,
I can jump in here, uh, I think I, I, I I think a lot of this has to do with history. So, for example, our first talk by Dr. Neidig highlighted the fact that there has most decidedly historically been a bias. Um, I mean, if you go back and you look in the 50s and the 60s of last century, so 1950s, 1960s, there was most decidedly a bias against women in the diagnosis of multiple sclerosis for a variety of reasons. First of all, we really did not have MR imaging. We did not have diagnostic radiology and early symptoms that may have appeared in women back in the 60s, maybe even up through the 70s. You were just attributed to hypochondriasis, hysteria, you name it. So there are many different kinds of biases that have existed in both uh, uh, diagnosis and treatment of various illnesses. Many of these biases are due to the availability, presence, or absence of diagnostic methods. Many of these biases are also can be attributed to the one of the other unfortunate historical aspects of the history of medicine, which is the division and separation between specialties. So, for example, there is most decidedly a long history of neurologists, uh, you know, measuring, quantifying, diagnosing loss of cognition. The MMSE has been around for a long time, focusing on decline in ability of thinking and speaking and communicating and executive function for level of cognitive retention of basic skills and abilities to talk and interact with other people. And it's not just the MMSE. There are several well-known, well-established surveys and questionnaires that have been used by neurologists to monitor and to track the decline of um, cognitive levels of function of a patient who ultimately suffers a demise from dementia. But again, here there are certain historical biases. For example, there has been a historical bias in the MS community in a variety of different ways. Let me give you two examples. One way was that MS was just, frankly, a peripheral motor disease, and there was loss of, ability to move arms and legs. That it did not impact cognition, and that it did not result in dementia. Well, that was a complete misnomer, a complete myth, a complete misunderstanding, because in fact, there always have been multiple sclerosis patients who did suffer dementia, and sometimes even at a very early age. So there are all different kinds of, if we use the term in the most general and broad way, biases that have resulted from whatever your designated clinical specialty was. Were you a neurologist? Were you a psychiatrist? Are you using this survey focused on cognition or that survey focused on mood and affect? So I think that this is one of the reasons why Brain Health Alliance has always used the term brain. It is one of the reasons why Brain Health Alliance has always attempted to promote a holistic approach. Let's look at the whole patient. Let's look at the whole person. Let's look at not just the brain, but the entire nervous system throughout the whole body. Let's not get caught up in which clinical specialty we have board certification in, but let's address the problem that the patient is experiencing. And to do that, we need a variety of different tools. Most of these surveys have historically been designed and developed and used to focus pretty much on one aspect of the person's ability to function in the world. It could be their cognition. It could be their mood. It could be their physical disability. Obviously, if we separate out vision, a vision test only focuses on vision. So the challenge for us, if we are taking a holistic approach, is what collection of different surveys or scales or questionnaires or exam tools do we bring together to capture the entire picture of the well-being or lack of well-being of the MS patient. We're going to need surveys for cognition. We're going to need surveys for mood and affect, et cetera, et cetera, et cetera. One of the goals of that composite scale done by the National Multiple Sclerosis Society was to not burden the MS patient. Can we bring a whole bunch of different things together in a single questionnaire so we can just get a quick glance, a quick view of the status, the welfare, the condition of the MS patient with a single questionnaire? So there in that situation, I do think one could ask this question about bias. So if and when we have a composite questionnaire, is it adequately capturing all these different aspects of the patient's well-being, from cognition to mood to physical disability, or does it have a bias that favors one of these areas over the other? And the way to get around this question or worry about bias of a composite scale is to do an assortment of different kinds of questionnaires that focus on different parts of the patient's life and well-being, which is why I asked my initial question, which assortment, which collection of questionnaires should we be using for our MS patients that adequately captures the well-being of the patient or lack of well-being, while at the same time not overburdening our clinical trial participants by asking them to do too many different questionnaires. And if some of these questionnaires are really sort of redundant and overlapping and not really helpful, then we should eliminate them from our clinical trial protocol. I've often used the ballpark, anywhere between 3 and 6, certainly not more than a half a dozen. I personally don't want to be asking any of our trial participants to have to mess with or complete more than a half a dozen different questionnaires. At the same time, I don't believe that even the MSS designated composite questionnaire gives us enough information in an adequate manner to appropriately assess and evaluate our participants. So, maybe a ballpark between at least 3, maybe 6, somewhere in there. And then the question becomes, which are the 4 or 5 questionnaires that we are going to select as most helpful and most appropriate for adequately capturing the state of our clinical trial participants. So I hope that gives a broader, more historical perspective on this question about bias. In other words, I don't consider the MMSE biased. It has always been designed for the purpose of evaluating cognition, but not mood or affect. Likewise, I don't necessarily consider the HADS biased, because it was always designed and developed to evaluate anxiety and depression. It was not designed or developed to evaluate cognition. So this goes back to, that old phrase or saying about, the right tool for the right task. And this is a situation where we're going to need a variety of different tools if we want to assess and evaluate a variety of different aspects of the patient's life and well-being. Okay, so that was probably a belabored, too long, lengthy of discussion, but I do think it is a very important matter, and we really need to address it in our 2024 amendment for our clinical trial protocol, because we really do hope to begin this summer, and we need to have a set protocol without any more amendments after this for the duration of the trial, accommodating the participants that we accept into the trial. I'm reluctant to make changes in the protocol midway through our study. So with that, let me just move us along, and I probably should breeze through my presentation as quickly as possible so we don't exceed the midday noon lunchtime hour.